It's my pleasure to be here. I'm Marina Curry, and I'm also really pleased to chair this with Wendy Brown and Barham Abudaya. I think, one of the things we've always talked about is Barrett's and things like that, but when we talk about bariatric surgery, we really are kind of doing things to the GI tract, messing with the myoenteric plexus, doing a lot of things. And so some of the findings that we have in our complicated patients really can be explained by esophageal physiology and also even GI motility. So we kind of crafted this session around that, and hopefully you will all be happy and learn something from this. So first, though, we're going to go out of order a little bit because Oliver Fisher is going to go first. He has to catch a flight. So he's going to come up and talk about Barrett's esophagus and sleeve, real association or a normal variant.
Thank you so much, and sorry that we had to change the order. It's one talk back, so it was no. One more. Nope, and one more. There we go. Okay. Okay, so thank you very much for the invitation to speak, and I'm going to start with this statement. And whilst I may be able to convince you of certain things today, bear in mind that I too may change my mind about this over time as I learn more. And I think in particular in regards to the topic of Barrett's esophagus itself, but in the context of bariatric surgery, there is still very, very much that we do not know or understand. So my name is Oliver. I'm an upper GI and hepatobiliary surgeon at St. George Hospital in Sydney. I've got no conflicts of interest that are of any relevance. And so I'm going to speak a little bit about the problem today, speak a bit about the incidence of Barrett's after sleeve, and then also focus heavily on actually what are the changes of the gastric cardia and lower esophageal sphincter following a sleeve gastrectomy. And I will also take a moment to put Barrett's into context because that's quite relevant. So why this topic? Well, most people who follow the literature have seen these insane numbers come out suggesting that up to 1 in 5 patients after a sleeve might be getting Barrett's esophagus. And why do we worry about that? Well, there are also case reports and case series out there suggesting that after a sleeve there are patients with esophageal cancer. And for those of you who do cancer resections as well, like I do, obviously if you don't have a gastric conduct anymore, that can complicate things a little bit. But so when this was starting off a few years ago, Wendy and I decided to try and identify the scope of the actual problem. So I was very fortunate to then work on this IFSO position statement where we really wanted to understand, well, what is the preoperative incidence of Barrett's, postoperative incidence, and is there any actually data regarding regression? That's been published. It's available to be read quickly. In summary, we included 56 studies after our systematic review and found that on a pre-operative level, because these are obese individuals, they're slightly different, the incidence of Barrett's on screening endoscopy was probably just around 6%. That's when we looked at the high-quality studies that were available. And when we looked at the post-operative incidence across all different bariatric procedures that were available, then we estimated about a 2% rate, but we're talking about sleeves today. And when we looked at the best sort of available data that was there at the time, we estimated that the prevalence of Barrett's post-sleeve gastrectomy during sort of an average follow-up of 2 to 5 years, you need to bear that in mind, was about 6%. Now that data is a little bit older. There's been just actually about a month ago a new systematic review published on this, but the rate hasn't really changed. They included pretty good high quality studies indicating about 5.6% of Barrett's esophagus after a sleeve. But when you look at newer studies also that have published on this, and there are high quality studies, this is from colleagues of mine from Switzerland, where I'm originally from, prospective cohort, very well followed. Parts of these patients were also part of the SMBOSS trial and stuff like that. It's interesting, the rates are not that high. So after sleeve gastrectomy and gastric bypass, there was no difference in the incidence of Barrett's. We're talking about sort of 3 percentage points. That's probably close to what we'd see in the general population as well. So yeah, and then we have other studies. Also, it's from Brazil, very well performed study, where very well documented cohort indicating that actually no patients after a sleeve had Barrett's. And this was a follow-up of 73 months, which is actually very long when we look at these studies, because most studies have only got about 2 years or 3 years of median follow-up. So I guess the question is, why this contradiction? Like, I mean, why do we see these things? And I'll leave you with this quote to think about it a little bit. It probably has to do with issues in trying to actually diagnose Barrett's correctly. And I think that this question has been very, very conclusively answered by work from Paul Burton and Wendy Brown. And Yasmin, who will be speaking today, is the first author of this paper. And I encourage everyone to read this, because it probably explains why we have studies reporting incidences of up to 18%. And I'll try and simplify this as much as possible for you. So on the top left-hand side, you've got pictures of Barrett's. This is biopsy-proven Barrett's, an irregular Z-line. They're fully documented. On the right-hand side, you've got pictures after sleeve. And you can see how one can easily think that this is Barrett's. Like, I mean, those of us who perform endoscopy regularly will see this, and if you're doing a quick scope, you might just think, oh, that's Barrett's, take some biopsy, and you may even get some intestinal metaplasia on your report that comes back. But what probably is happening is, due to the alteration that we are doing of the angle of His and of the stomach and tubularizing the stomach itself, we know that probably over 2/3 of patients, when we do scans on them, have got migration of the top part of their sleeve into their chest. And so what our colleagues in Melbourne very clearly explained and documented over a very, very meticulously performed study was this tubularization of the cardia that occurs during proximal migration to then mimic what might look like salmon-colored mucosa coming up towards the Z-line. And the reason also why it mimics that is because it's flat. The gastric folds are being actually pushed down a little bit, so you actually truly think that this could be flat tubular mucosa, but that was on manometry documented with these patients who had this proximal migration due to be higher pressure in this part of the stomach that probably just leads to flattening of the mucosa itself, thereby creating the impression that you actually have endoscopic Barrett's, but it wasn't truly there. And I think that that's just something which one has to bear in mind. And all of the studies that we've included also in our meta-analyses, they do not contain enough information to be able to identify what the endoscopists were actually seeing and what they were thinking at this time. And we're speaking about the cardia. And I mean, this, if you want, no disrespect to the authors, but if you want a paper to put you to sleep at night, this paper on the gastroesophageal junction, because this is the area of the human body we're talking about, is probably the best explanation of what goes on in this area. And it was aimed towards to try and identify what is the cardia, what is actually this area of transitional epithelium that happens. And as you can see, this is a normal endoscopy as well, and you have this phenomenon of cardiac mucosal effacement that can occur. And it's about a 1 centimeter area. And what has happened based on this consensus meeting was that the terminology of ultra-short Barrett's esophagus, so Barrett's less than 1 centimeter, is being highly questioned because it's probably just cardiac mucosa with some intestinal metaplasia that is being seen. But that is not the same thing as true Barrett's esophagus. Interestingly enough, they looked at risk factors for IM, so intestinal metaplasia of this transitional zone of epithelium, gastric acid common, but bile. And I think bile frequently gets forgotten as a cause for this problem. And when you look at our colleagues from Melbourne's paper, in almost 40% of their endoscopies did they find bile in the stomach. And I don't know what you've experienced, but I find that very frequently when I scope patients post-sleeve, that in the antrum I'm going to be seeing some bile as well. So maybe that's what's contributing to the intestinal metaplasia of the cardia, and we're getting cardiac mucosal effacement, and that's what's making people think, this is Barrett's, but it isn't. It's something completely different. I'm going to take a quick moment here to jump over to something else. This was shown by Lee Kaplan as well at his talk, and I think this is really, really important. People talk about Barrett's, and I think they don't really understand the condition. We're all worried about cancer. But yes, Barrett's is a risk factor for cancer, but the overall risk is really low. And the risk is not absolute. It depends on many different factors. These are well described, well looked at, and these are the things that can drive cancer formation. We tried to set out to understand, what is the exact risk of progression in one of our studies. And what you can see is with every decade of published literature that goes on, the incidence comes down. And when you look at the newer studies and you take just all Barrett's comers, the risk of malignant progression to either high-grade dysplasia, so not invasive cancer, or intramucosal or invasive cancer is 0.3% per annum. Of course, dysplasia is a risk factor, and you have to factor that in when you're assessing the risk of cancer formation in your patients. And also the length of Barrett's. And this is also where we have to talk about the bariatric studies, because most Barrett's that's been identified is not sort of your 6, 7, 8 centimeters of Barrett's. We're talking about 1 to 2 centimeters of Barrett's, maybe even 3. And the risk of malignant progression is equally proportional to that. The shorter the Barrett's, the lower the risk. Shown in meta-analyses as well, when we talk short segment Barrett's, so less than 3 centimeters, the risk of malignant progression is only 0.06%. What about women? It's different again in women, and most of our bariatric patients are female. And gender disparities exist in cancer, but also in terms of the malignant progression. The risk is 0.1% for women versus 1% in men, so 10 times less. This has also been shown in other studies, up to 6 times less risk of progression. It levels out when they get over 80. That's probably due to other factors. And that's been shown time and time again that actually malignant progression in women is a very rare phenomenon. And then I guess you have to ask yourself, well, do patients with Barrett's actually even die of cancer? The answer to that is no. They die of metabolic conditions, cardiac disease. They die of things like stroke or ischemic heart disease. They die of other cancers than their esophageal cancer. These are well-performed population studies indicating that the risk of actually dying of cancer just because you have Barrett's isn't that high. And what does bariatric surgery offer? I don't know. I'm in a bariatric conference. I don't have to explain that. We're talking about extending people's lifespan. And to finish off, the greatest tragedy of science is by slaying a hypothesis with an ugly fact. Does Barrett regress after a sleeve? Yes, it can. We're seeing more and more reports coming out. This is a case report. This is a study from our colleagues from the Gold Coast, 83% regression of Barrett's. And in our colleagues from Melbourne, patients who had Barrett's who had a sleeve, 38% to 40% saw an improvement of their Barrett's. So I'm going to jump over because I'm running out of time. My apologies.
You're okay.
Oh, no, I'm not? I thought it says 12, 15 minutes up here. How many minutes am I? Okay, sorry about that. But again, sorry, I just wanted to jump in terms of the risk of sleeve and cancer formation. That has been published as well. That risk, it does not seem to be high. Paul Burton did bring up some caveats at this discussion yesterday in terms of length of follow-up of the studies. But I mean, if we take Caroline's paper that she presented yesterday, I mean, this is phenomenal data that's indicating that the risk is not as high probably as we worry about, even when you get into longer follow-up. I'm going to make a comment on screening endoscopy because our guidelines recommend if you've had a sleeve, you should screen the patients with endoscopy probably about every 3 years. That doesn't align with the Barrett's guidelines, number one, so we will be changing that. Number two, one has to think about this practically, okay? If we use the numbers that I've thrown around today a little bit and say your program does 100 sleeves a year, just as an example, okay? If you look at sort of what happens over a year and assume a rate of Barrett's of about 6% at 5 years, when you've reached 1,000 sleeves, you're going to have this number of patients, the blue down there, that have got Barrett's. If you then think about a malignant progression rate of 0.3% per annum, we're talking about 2 patients potentially that may have either high-grade dysplasia or early esophageal cancer, and that's in 1,000 patients. So you have to screen 1,000 patients to identify 2 cancers. And we know that we perform much more. This is from Australia. We perform about 50,000 sleeves every year. And if you expand that to a population level, you really have to ask yourself if this is a cost-effective way. The reality is, we know that for Barrett screening itself, that it's probably not cost-effective to be doing it with regular endoscopy. So one has to be a little bit careful when interpreting those guidelines. The other thing is, we have a fix for the Barrett's. We know that if you convert these patients to Roux-en-Y gastric bypass, that in many, 2/3, the Barrett's regresses or stabilizes. So it's not like we don't have anything that we can do about this. And so I hope I haven't confused you too much, because there are a lot of things going on in this space, but I'll summarize by answering this question as far as I can today. As I said, I may change my opinion on this down the track. Is Barrett's actually just a normal variant that we see of the anatomy? Probably. Cardiac mucosal effacement with tubularization of that part of the stomach is probably what's happening, and that's been very well documented. However, there is intestinal metaplasia that is present on the biopsies, because we do have studies that have looked at histopathological features of intestinal metaplasia. And we do know that intestinal metaplasia, even at the cardia itself, probably matters, but the risk of cancer is probably even lower there than we think. And I'd like to end by saying you can always convert the patient to a Roux and see if that helps. Thank you for listening.
Thank you. Because Oliver has to leave for a flight, we do have discussion time at the end, but we're going to take, if you guys have any questions for Oliver right now. But I have a question for you before, if that's okay. It's not a false narrative, that seems aggressive, but saying this about the cost of screening for those, 2 patients in every 1,000 that you might find something, and you're saying that's an added cost, and yet, do you believe in screening colonoscopies? Right?
Look, I work in a country, Australia, where we have a national bowel cancer screening program with fecal occult blood testing. That's a much more cost-effective way of doing it. I think that when we discuss costs, it's a very, very difficult and complicated conversation, because you have population health and you have the individuals that it affects. The reality is that the incidence of cancer post-bariatric surgery with the data that we have right now, so esophageal cancer, is lower than the population incidence. So it's very hard to make an argument that we have an at-risk population for cancer and therefore we need to screen them, which is usually what we do, and that would be a good argument for me to say, okay, we can screen them. So right now that evidence is not there. In terms of screening them for Barrett's, though, if we're going to say that I was wrong with my theory about cardiac mucosal effacement, then we'd have to say, well, we have a population that's probably got a 2 to 3 times increased risk of Barrett's formation compared to population. So there maybe screening would make sense, but we have to ask ourselves, what are we trying to prevent with screening? And that brings me back to the cancer incidence. And I don't think that cost effectiveness is really there at this point. I know, it's a difficult conversation because not all healthcare systems work the same, but in Australia with a single payer healthcare system that we have, we can't just willy-nilly go and spend $750 on an endoscopy on every single patient when we're doing 50,000 sleeves every year. It just doesn't work.
So 2 questions, Oliver. Great presentation. One is, these studies do not factor in the weight regain or weight recidivism. And as you know, this is the biggest risk factor at baseline in obesity, because that brings back the inflammation, which is the biggest risk factor we know from transition from Barrett's to high-grade dysplasia to cancer. So one point I would challenge back on is we need longer-term follow-up beyond 5 years, because that's when you see most of the weight regain. And the other thing is the phenomena of metaplasia of the cardia is not benign, and that's reflecting in the Seward classification of cancer, right? Seward 3 is the nidus of the cancer is at the cardia from intestinal metaplasia. And so that is, the jury's still out on that. What's the significance of cardia metaplasia? But it's likely to be significant and pre-malignant condition.
So I'd agree on the latter point that for CEVA2, actually, which are true transitional zone cancers, that the intestinal metaplasia probably plays a role, but we don't understand exactly the pathways as well. I think in terms of weight recidivism or weight loss, because there's a risk mitigating effect from the weight loss as well. And then, yes, something happens again when they weight regain. The reality is we've got no idea. We don't know how any of those changes actually affect things in this area. One thing I'd say, though, is that there's pretty good data in the Barrett space around that would indicate in simple terms that the Barrett's you get from the beginning determines your risk of malignant progression because of its genetic composition. And yes, we do see that over a long duration, the risk goes up as well, but probably what matters more is what was the genetic composition of your Barrett's when it developed. So is it a p53 mutant pathway or not, etc. And that's where more research needs to come in, because what we don't know really is the Barrett's esophagus of the obese, the same as the Barrett's esophagus of a lean person, and that's where all those mitigating effects come in, yeah.
And just, I've done some research on this as well, but long segment versus short segment. You mentioned, one centimeter, but if you have something that's more than 3?
Yeah, I mean, look, for me personally, so I don't find short segment Barrett's a contraindication to something like a sleeve, but long segment Barrett's I would definitely pause. Like, that to me is a very different condition, and also because our ability to capture the field defects throughout that segment are very limited. I mean, the Seattle protocol helps, but it still, so for me, a long segment Barrett's patient really is quite a different condition than something that's 1 to 2 centimeters.
Anyone else? Questions? Okay, well, thank you so much for that. Thank you.
Thank you, Oliver. So now it's my great pleasure to introduce Dr. Yasmin Jahari. Yasmin's just finishing her surgical training here in Melbourne and is going to be doing upper GI and metabolic bariatric surgery fellowships through our NSCOSA program next year, but she did her PhD with us in Melbourne on the physiology of metabolic bariatric procedures, and she's going to explain to us today what normal looks like after bariatric surgery. So thanks, Yas.
Thanks, Wendy, for the introduction. As Wendy's mentioned before, it's clear I'm not an expert. I'm a trainee, but I did focus my research on sleeves and physiology and pathophysiology with Wendy's help and the whole research group. So here we go. I have no conflict of interest. So today I'm going to focus on sleeve, and this is why. It's because it's still the most common procedure done worldwide, especially in Australia and New Zealand as well. And this is more of a proof of concept of why we need to know what's normal. Clearly, the rapid rise and uptake of sleeve since its introduction in 1998 have overshadowed its physiology and pathophysiology understanding. We know it works, great weight loss, comorbidity resolution, some studies even compare them to Roux-en-Y and AGB. But it does have its issues, weight regain, poor weight loss, reflux, and staple line leak. And these are difficult problems to fix. They cost money for our healthcare. Patients don't like them, patient dissatisfaction, medication long-term, and reoperation. So they're big problems that we need to solve. And why do we need to know what's normal? It's because of its implication. We can't expect an altered gastrointestinal tract to function the same as a normal gastrointestinal tract. They must have a different physiological mechanism. And with saying that, patient might present with different signs and symptoms, and how do we interpret them? And furthermore, diagnostic tests that we use to determine normal patient with reflux or other conditions should be different in a surgically altered stomach. And this will impact on our decision-making, particularly when to reoperate on this patient. And it will help communication between other surgeons, other health team members, as well as to the patient itself. And lastly, we can utilize these findings from understanding the physiology for research trial, as well as to measure the outcome if you change something in your procedure or give another treatment. So this is how I set out to do my PhD, but I think this can be applied to all gastrointestinal surgery as to how we go about it. We need to know what's normal physiology, and then we can define what is the abnormal pathophysiology, and then identify the threshold of what's the new normal in the tests that we perform for our patients and the variables that we collect. Apply this in the clinical trials, and finally apply in a clinical setting where we can measure the outcome of intervention. So step one, what's normal physiology look like after a sleeve? We did a number of sort of sequential studies to try and answer this question. This might by no means is the answer to the whole question. So we had optimal patients who were asymptomatic, great weight loss, with more than 4 months after the operation compared to match controls, basically. And they underwent a series of tests, including a nuclear medicine, manometry, pH, barium, and fluoroscopy and manometry combined together. Unsurprisingly, we found rapid gastric emptying, like most of the studies out there. Interestingly, within the 2 minutes of scanning, a large portion of the meal is actually in the small bowel, so it's like really rapid. And interestingly, we found that the esophageal emptying looks the same as the gastric emptying in sleeves, compared to the control, which is completely separate. So there must be some sort of esophageal peristalsis helping with gastric emptying, basically. We found reflux, and these are asymptomatic patients. So these are scans taken after 60 minutes of ingesting a semi-solid substance, and they're more common after sleep than control. We also found postprandial reflux within 90 minutes of ingesting semi-solid substance. And again, asymptomatic patient. We also found bile reflux. In this study, we got asymptomatic patient to have a HIDA scan to prove that the bile are being secreted into the stomach, and then we quickly moved them to a PET scan to get the reflux, no, not PET scan, nuclear medicine scan, gastric emptying to get the reflux up into the esophagus, so we know that bile actually goes into the esophagus. Now, we did a manometry, but with a specific point to measure the proximal intragastric pressure. So at the start, when they're not swallowing anything, their proximal intragastric pressure is actually not elevated. But as soon as they drink successions of water, you can see the pressure rapidly increasing. And at the same time, when we do nuclear med, sorry, that thing is not playing, you can see reflux coming from the stomach into the esophagus. So then we did a stress barium to look at the emptying of the stomach. And we saw this bicompartmental model where the incisura acts like a little sphincter. And the pressurization of the vertical compartment helps the incisura to open, and then stuff flows into the antrum. And we correlate that with doing manometry and fluoroscopy at the same time, and you can see the high pressure as the vertical compartment of the stomach feels as the esophageal contracts down. And then as the pressure gets to a certain point, the incisura opens and stuff flows into the antrum. But we also saw reflux that stimulates secondary peristalsis of the esophagus to help push things down. So maybe actually reflux is something that happens regularly after a sleep, and it's something that's actually important for an emptying. Don't know. So that's where we got with the physiology. So then we said, okay, so reflux are common. Reflux probably help with emptying to get that secondary peristalsis moving. What is abnormal? Now that we saw the nuclear medicine studies and pH studies showing reflux, and these people are asymptomatic and has great weight loss and doesn't have Barrett's esophagitis. So we set up to get a group of asymptomatic patient and symptomatic patient, put them through the same test, and compare them. So we found that after sleeve gastrectomy, your 24-hour acid exposure are high, but is a lot higher in symptomatic. They also have more supine reflux events and more number of events over 24 hours. And we're like, oh, okay, maybe it's to do with the high pressure intragastric, hence particularly in people with a lot of separation between the LOS and the diaphragm. So we tried to correlate that, and that didn't show anything. So it showed that there's no difference, and there's no difference between the axial separation and the acid exposure in the esophagus. But we found that people with symptomatic reflux have more triggered deglutative. So this is the reflux within the 60 minutes of ingesting the semi-solid. And there's more things bouncing up into the esophagus than people without symptoms. Similarly, they have more postprandial reflux. And they also have this pattern of irritant reflux, where every time they swallow, their intragastric pressure go up and more reflux can pick up. So we've then defined these 3 different paradigms of reflux, and this then puts us towards getting, okay, so what's the threshold, what's normal, what's abnormal? We did a number of ROC curves comparing pH studies values with their symptoms, and we found a number of thresholds that we can use to determine that if you found this in your pH study and patient complain of symptoms, they have reflux. We also use the same criteria for patient who, or nuclear medicine study, with patient with poor weight loss. So we found that they have more food stuck in their proximal compartment as it dilates compared to the patient with optimal weight loss and no reflux. And a gastric emptying of 21 minutes we consider a normal value compared to a normal stomach where it's 40 to 60 minutes is what we use in our hospital. So it's clearly major alteration of stomach, and these actually, if the emptying goes back more towards a normal stomach, that actually is abnormal. So, for example, in my hospital, when we report our gastric emptying studies, there's always a normative value, and they're like, normative value 40 to 60 minutes. But if you see a sleeve patient with 40 to 60 minutes, it's not normal. And thank you, Oliver, for mentioning this paper, and then we found this. So this is due to the alteration that we made during surgery, but also the proximal intragastric pressure that happens every time the patient swallows, pushing that cardia up little by little. And when we did the study, on our biopsies, we didn't actually find intestinal mesoplasia. We found gastric cardia with no goblet cells. So step 4, we're going to try and use these tests to see, okay, what happens if we take all the patients who have problems with reflux after the sleeve and give them another operation to accelerate emptying? So we know they have slower emptying, hence if we can increase it, maybe we can decrease their symptoms. And we saw the same thing. So we saw that their gastric emptying improves after OAGB, they have less reflux on nuclear medicine, and they have less intragastric isobaric pressure, which is what we were trying to achieve with an OAGB. So in conclusion, we did all that. So we started off with, okay, what's normal? And then what's the pathophysiology of reflux in this patient? And then what is the normative value we can use to all of these tests that we normally use in our clinical practice? We haven't really answered that question fully, but we certainly have touched a bit on it. And then we use that to the second part of our study. Well, these people with problems, let's try and fix it and see if the numbers improve. That worked. And now so in our current practice, in my hospital, we changed our nuclear medicine protocol in terms of reporting, as well as pH manometry and gastroscopy for sleeve gastrectomy due to this. So take-home message, it's important to define what's normal physiology in every gastrointestinal operation, not just sleeves and not just bariatric. But this is a bariatric conference. It is important that we try to use a multitude of tests in a structured manner, simple and complex tests. And even if we do complex tests like a combined fluoro and manometry, we can end up using that to interpret the simpler tests that we would use in our clinical practice. But we need to make sure that we have done our due diligence and more clinical trials and observation data is required before we can use this fully in our practice. Thank you.
So I think we're doing questions at discussion time at the end, so thank you very much, Yaz.
Fantastic lecture, thank you. It's my honor to present Dr. Michael Talbot, who is a very experienced surgeon, but also a very experienced endoscopist. He's gonna talk to us about why do people experience reflux after sleeve gastrectomy. I think the previous speaker made it easy for you, so it's they all have reflux. So.
It's great to be here, my disclosures. I'm going to get people to disagree with me early, that way you'll maintain your attention to what I'm talking about. I'm coming at this at a slightly different approach. As a clinician who looks after a lot of patients with post-surgical complications, so the way I've constructed my analysis of these patients and some of my theories and thought process is a little bit different. But yeah, the sleeve does not cause reflux. This is my conclusion. So you can go to sleep if you don't want to hear the rest. But some patients do get reflux, and I mean a clinical syndrome of reflux. But this is related to patient factors and surgical factors. And this is really important because a sleeve gastrectomy, when compared with our other surgical procedures, produces, on average, clinically identical outcomes with regards to weight loss. Sure, there's a couple of points BMI difference, on average, better at 10 years with a bypass than a sleeve, but it's quite likely not clinically significant for a lot of our patients. There's also an issue with how we look at reporting symptoms. All bariatric procedures within the first year or two fix subjective sensations of reflux. So talking about reflux only as something that's measured and assessed in the first year after surgery doesn't actually make much sense when the perception of reflux and the symptoms and the treatment that these patients undertake occurs years after. And again, when you go and look at patients reporting symptomatology that might be treated as reflux, there's not a big difference between our procedures. A lot of our patients are on PPIs, sometimes for reflux, sometimes for other things. So, reflux isn't caused by sleeve gastrectomy. What causes reflux? There's a number of things that we know are associated with reflux. I've highlighted the things that we can measure. So if we really want to know what's happening with our patients, we can measure it. We can measure their peristalsis, their lower esophageal tone, their intragastric pressures, their esophagogastric junction compliance and distensibility, and there's some things we cannot measure, such as visceral sensitivity and mechanical and visceral factors, metabolic factors associated with obesity that promote reflux. Although we can guess the visceral sensitivity patients, because these are the ones with strong symptomatology without objective evidence of reflux. And we know that the more a patient complains of reflux, the more likely it is that they have a non-reflux diagnosis. A patient who's not responsive at all to PPIs probably doesn't have reflux. And this is important. It's good to measure things because we shouldn't be offering patients reoperative surgery based on empiric theories of pathophysiology. How do we investigate reflux drivers? Endoscopy, unfortunately, this is poorly done, poorly reported, and subjective. We're not that good at writing reports that other endoscopists can read. Barium studies are really good in the esophagus, but they're terrible in the stomach, so I tend not to use them. I tend to harp on about 3D CT, and I'm going to have a session on that because I love it so much. Manometry is objective, but it's often poorly done. People cut corners. It must include bolus assessment, must include intragastric pressures, and must include solid swallows if you're going to get a decent analysis. So a lot of the work that Yasmin has shown included all of this as part of their routine assessment, and you should be demanding it of your esophageal physiology services. Peristalsis briefly. There is a disagreement about whether reflux is a contraindication to sleeve surgery, and I think it all depends on what causes it, whether it's surgically reversible or not. But patients with strong predictive factors for a peristalsis should probably be excluded from LSG. So previous band patients, you've got to approach with caution, patients with dysphagia, bad esophagitis without a hiatus hernia, and patients with a poor PPI response to reflux pre-surgery are a good group that you can shunt to the side or at least investigate, I think, before operating on them. What should a normal sleeve look like? We've seen some examples of a normal sleeve. It should not be wider in the vertical component than the transverse component. And you should be able to see all these anatomic features. You can always see where the esophagogastric junction is. You want to know, like the picture on the right, how big the esophagus is, because a large esophagus is a strong suggester of a hypoperistaltic disorder. You can see the angularis, and you should be able to see the polaric notch. So this is a relatively straightforward but fairly short hiatus hernia with a normal looking esophagus above it. This is a fairly complicated looking patient who's got a hiatus hernia, plus some asymmetry, and a very tight angularis stenosis, for example. One of the problems we face is that changes occur over time. So the changes that follow surgery are maladaptive for reflux. And we know this because most of the patients we are seeing are presenting 5, 6, 7, 8 years post-operatively. Immediate post-surgical patients' problems are rare, and they are either related to grossly distorted physiology, so aperistalsis, or a hyperperistaltic esophageal disorder like jackhammer esophagus, or a disordered response to surgery. 2 or 3% of our patients will develop hypersensitivity syndromes associated with your surgery. We don't want to double down and create another surgery for them because they've got a hypersensitivity syndrome. Or there can be obvious anatomy fails like the previous slide with the tight angularis. Sleeve dilatation occurs over time. The antrum dilates a lot if it's not stapled, but it doesn't dilate at all if it's stapled a bit. The angularis never dilates. The vertical component will dilate over time. So if you've got a slightly narrow angularis and a slightly floppy proximal stomach, that proximal stomach will dilate and will fail to empty, and the patient will present with symptoms 5 to 8 years down the track. We also have this issue with reflux is highly associated with telescoping of the stomach into the chest and esophageal anatomy and functional changes. So you get movement of the lower esophageal sphincter and changes in its function and distensibility, and both of these things likely contribute to reflux. Assessment of hiatal hernia at the time of original surgery is almost entirely subjective. We know that telescoping of hiatal hernia occurs after sleeve gastrectomy. We know it's highly associated with development of reflux esophagitis. One of the things is when you're operating on somebody and you're looking at the esophagogastric junction, you're just looking at the area where it is, not at it. We can assess reasonably well axial separation within a limit of the OG junction at the time of surgery, but we can't determine radial separation. This area is highly packed full of fat. As the fat disappears, you get increased mobility. So what you see at the time of surgery, because you're just looking at it, not through it, may not be what happens a few years later. When you get a hiatus hernia, what happens is the diaphragm and the intrinsic parts of the sphincter separate. As it separates, the sphincter lengthens and weakens, and then it suddenly shortens as you get distraction. When you've got overlying crural and internal elements, each element contributes about 10 millimetres of mercury to the lower esophageal valve pressure, with a little bit more from the phrenoesophageal ligament. So this is what happens. You get a longer but weaker sphincter over time. Added to this, when you've operated on these patients, you get esophagogastric junction telescoping. So if you've cut the phrenoesophageal ligament during your surgery, the first time the patient swallows in recovery, the esophagogastric junction will move into the chest, and because the staple line is sticky, it might end up staying there. So it's quite common, or it's a culturally common thing in Australia when a lot of us do hiatal hernia repairs for bariatric surgery and non-bariatric indications to include as part of that a modified Hill repair, just to make the attempt to keep things where they should be for the first few months. When you take this type of approach of operating on patients, reconstructing the phrenoesophageal ligament if the patient has a hiatus hernia, what you'll see if you study patients pre-surgery and 6 months after is preservation of the lower esophageal tone, normal length, normal function, and only small hiatal hernias. And with reflux studies, the risk of 24-hour increases in acid exposure time doesn't seem to happen. So the measured 24-hour reflux associated with this type of approach at 6 months is the same pre and post-op. What happens 5 or 6 years later? I don't know. Other people have looked at doing The same type of modified Hill repair, and again, when they look at their results, post-operatively, a reduction in esophagitis and a reduction in telescoping. But wait, there's more. As Yasmin said in the last talk, the esophagus acts like a pump. And it acts like a pump for all of our gastroplasty procedures, and is probably one of the reasons why our patients get reflux and their procedure fails down the track, is because the pressure transmission to the area overwhelms its function. So failure and fatigue and late failure of this complex leads to dilatation of the distal part of the esophagus. It's not common to get full dilatation, but distal dilatation is common. And this mechanism of failure will be seen in all gastroplasty patients with bands more than sleeves, sleeves more than bypasses. This has been shown by one of the studies that Barham's done, looking at endoflip, which looks at both distensibility and secondary peristalsis in patients who have had surgery or haven't had surgery. This is what a normal pattern looks like. Aperistalsis, you get nothing. Retrograde peristalsis, you get the bolus bouncing up out of the esophagus towards the throat. When you look at patients who have had, now is there a laser pointer here that works? There is. Abnormal motility in patients who have had gastric bypasses in their series, which was highly selected, 60%, sleeve, 60%. Normal obese patients, only a third. Patients who have had previous surgery like Nissens or having revision surgery, 80%. So if you're doing a revision for reflux after a sleeve, it's 80% likely, and that would be my guess, that you've got a problem with distensibility and a fatigued and slightly damaged lower esophageal valve, which is why so many of these patients still have reflux afterwards. And this is a way of looking at the distensibility, that post-surgical patients, sleeve and bypass, get abnormal distensibility. Previous fundo and other more complex revision patients, highly prevalent. Being obese isn't sufficient to affect your distensibility much. And you'll see this anatomically when you operate on a patient. How much time do I have?
You okay?
Okay. Rattling through it, sorry. When you look at these patients, it's quite common to see a left-sided dilatation of that lower esophageal segment, and some of it might be a dilatation of the vestibule of the lower esophageal sphincter. Some of it might be the cardia migrating underneath the esophageal muscle. This is showing the phrenoesophageal ligament where the diathermy hook is, but it's probably a bit of cardia has slipped up underneath the phrenoesophageal ligament. And you'll see this quite frequently in patients with reflux after band, sleeve, bypass, and Nissen. So patients, if you make an abnormal sleeve, may initially tolerate it, but will develop symptoms down the track because of a late fatigue phenomenon. So our early studies that we do will now need to, I think, correlate to later studies and figure out what changes over time. What is normal sleeve configuration? Well, it's difficult. Any non-reinforced tube that bends will kink. Our sleeves are created bent, and any angular stenosis, I believe, will progress over time as the stomach lengthens. So we've looked at our sleeve patients. The tube lengthens over time. The length of the stomach is strongly correlated to the time since surgery. Also, we observe that these patients get a widening of their stomach over time. That has an effect on changing the angle at the angularis, so it becomes more acute. And that will probably increase wall stress and change flow and change gastric emptying. But we also see crimping, so the greater angulation will lead to greater crimping and increase of obstruction and stenosis. When you do a 3D CT scan, you'll always find at least a 25% difference in cross-sectional area at the angularis compared with the stomach immediately above it. So from a stapling point of view, try to make your stapling 25% wider than the bougie at the angularis if you want to ablate this problem. And do we see this being a problem? We do. We get these sorts of things. And that's even worse if it's that sort of thing. And it's sometimes difficult to know with how to treat these patients when you get them turning up with symptoms. This is how we report our CTs. We report the esophageal diameter, the axial separation, the diameter proximally, the diameter distally, and the cross-sectional area at the angularis. And when we've gone back and looked at results after revision surgery for reflux, we see that there's a strong correlation between a disparity at the vertical component and the angularis, that these patients were highly likely to turn up for surgery, and if you operated on them, they were more likely to get a good result. We weren't operating on patients with functional abnormalities. Can you get away with just fixing the hernia in some of these patients with post-sleeve reflux? I think so. When you look at patients late after sleeve gastrectomy and they've got a lot of reflux symptoms, you'll see this type of pattern, stacking of the bolus as they swallow and as they eat. And if you do manometry on patients before and after repair of hiatal hernia after sleeve gastrectomy, you'll see normalisation of some aspects of esophageal function. And then if you ask them about reflux control, you can find good results, but the good results are not uniform. If you look at the published literature, the results for sleeve hiatal hernia repair alone in controlling reflux is probably only about 50%. In our own hands, when we've excluded patients with sleeve configuration and abnormalities, so we've looked at the sleeve below the diaphragm to get rid of angular stenoses, excluded peristaltic failure, and performed sleeve hill repair with plus or minus mesh, about 70% of patients are happy with the result, and only 10% come back for a bypass, whereas our happiness with reflux results for sleeve to Roux-en-Y is about 80%. When you study your failures, you'll often find a result. So if I've operated on somebody for reflux and they don't get a good result, I'll usually see reherniation, abnormality below the hiatus. Some patients get retained entrance syndrome or an incorrect initial diagnosis. So this patient had a sleeve to bypass for a jackhammer esophagus, so they didn't get better until they had a POEM. Thank you. Sorry, it's a bit of a race.
Thank you so much. So we're going to continue. It's my pleasure to introduce Dr. Shanal Kathari, who is past president of ASMBS, and he's going to be talking about is bypass the answer, reflux and other functional gut issues after Roux-en-Y and OAGB.
All right. Thank you so much, Dr. Kurian. It's a privilege to present here before you today. I'm the last speaker between you and some ghrelin suppression. So we'll try and move this along and then get to the Q&A, which is far more important because I have so many questions based on the three great lectures we've already heard.
You're done.
That was it. Thank you very much. Any questions? All right. I cannot see.
Yeah, can you get his talk up
It's up here, but it's not on the
on the monitor?
on our monitor.
There we go.
All right.
There we go.
All right. Is there a way to go
think
back?
it's good.
Let's go backwards. All right. So these are my disclosures, none of which should impact this talk. The other disclosure is I am not a gastroenterologist or an advanced therapeutic endoscopist. I work closely with those in my practice, as we're going to be talking about some more functional things here as well. And then my other disclosure is I was against the OAGB before I was for it. And, but I can also, I'm a data-driven person, and I was eventually swayed by the evidence, including pioneers in the U.S. like Helmuth Billy, a dear friend of mine, who forged along and presented the data to the ASMBS For many years, it was not approved by ASMBS originally, and then more recent years it has been. And so I think those of you who continue to persevere and convince people such as myself that it has a place in our armamentarium. The procedures that I'm going to be focusing on, again, are highlighted there in red, the GERD, and I want to talk some on SIBO. The rest of the things are more mechanical and not functional, and most of us have plenty of experience in how to manage those. But GERD, even after gastric bypass, we've heard some great lectures on, we just heard about sleeve reflux, but it still happens after gastric bypass. And this is in one of those chat room forums, and believe it or not, this is a surgeon who used to work at my institution. And here he is, even more senior to me, struggling with a patient who has GERD symptoms after gastric bypass, and he's asking the world what to do. He's got 16 responses. There were about 16 different answers that were given to him on what to do with this, which tells you what, that we don't have any one perfect answer for these situations, but popular as well by 39,000 views there. The other thing is, again, I think it's very important to know how are we going to diagnose GERD? Is this by HRQL, which, as we know, a study I published with objective data shows zero correlation to the pH score on patients, but doesn't change the fact that they act as their own internal control when their scores are high before surgery and they go low afterwards, which is great for symptom. But what did we do in terms of moving the needle on objective pathologic reflux per se? I think that's still to be determined a little bit. And an opportunity for future research. But we can see, at least based on the SMBOSS trial, what the incidence of worsening versus de novo GERD was after gastric bypass. Some other contributing symptoms, we also heard some of these before. I think this idea of the esophagus and its role in peristalsis is very important. I think, Baram, I don't know if you coined that term, post, but I give you credit for it. Post-obesity surgery, esophageal dysmotility, I think this is real, and this is something that we need to continue to keep an eye on. Higher probably after sleeve than after a bypass or an OEGB. We talked about the high pressure, Michael talked about the higher pressure conduit and what maybe that does to that pump. Over time, it gives out when it's trying to work against that resistance. And so I think when we see particularly the popularity of sleeve in Australia, and certainly it's #1 in the US, I think this is something to keep an eye on over time as well. Other things there listed could all be contributing factors as well. We also know, we talked about the role that the hiatal hernia has, a significant component, anywhere from 50 to 80%, perhaps based on studies of what that does to the lower esophageal sphincter component. The candy cane, don't forget about what that can do. That can be that little reservoir that sits over there. And I usually watch live, have the upper GI and have them take the barium-soaked marshmallow or the 13-millimeter tablet, and like the pinball machine, if it goes down and it wants to sit in there and that reproduces the patient's symptoms, and then that's when I feel convinced that I should go and resect that piece off of there. The acid pocket can occur, and pouch stasis, again, if we're making too big a pouch, you're going to increase your risk for reflux and or marginal ulcer. I have the original book from Dr. Mason, my former chair, trained under him, and it's great to read the original history of this. When if you look at understand our medical school pathophysiology, if you make too big a pouch, then what you do is you have acid in that pouch, and then you don't have enough acid in the antrum going into the duodenum, so you don't have enough acid to turn on secretin, which tells your body to say to turn off the acid pump. All of our body's designed on feedback loops, and when you can't turn that feedback loop off, it stays on all the time, and that's where we're getting our marginal ulcers. So obviously the answer is make the pouch small, and that was in Dr. Mason's original conclusion of that chapter in his book, over 40 years ago. We know other things, of course, from a technical standpoint, distal obstructions and the dreaded Rubino configurations, other things that can contribute to these symptoms as well. Now, I was privileged to be asked, Baram had put together all nationally recognized experts in reflux disease and bariatric surgery, and then me, to be authors on this as well. And this is, I'm not going to spend in the interest of time going through every aspect of this algorithm, but I do think it gives if you can get this reference, download it and study it, because I do think it will help guide you in your management of these patients, specifically around the one-stop shop. Now, I don't know, raise your hand if you have the technology and or ability to do, whether it's you or within your system, endoscopy, a Bravo pH probe, and EndoFlip, all simultaneously on the patient to gather that information. So there's only a couple of us. Okay. So the key is, if any of you are going to move and take a different job like I did, you have to put it in your contract that you're going to get the EndoFlip technology. So now we have that capabilities, and we've been doing this one-stop shop at my institution for these patients to gain the most amount of information with the least amount of disruption to the patient. So again, if you can do that, that's great. Now, what are you going to do for that patient that you have documented GERD after reflux? And I do, based on the elegant talk that you gave, I want to hear the panelists talk a little bit on, should we have, what are the thresholds for reflux? Are we supposed to use the same Demeester score for somebody who's missing half of their stomach from a sleeve or even a gastric bypass? I mean, or not. I struggle with this. But nevertheless, if you've made the diagnosis of reflux, we do have some other less invasive interventions. I've done a handful of these in my practice. I still think STRETA, or radiofrequency ablation, potentially has a role as a non-invasive option. Anti-reflux mucosal ablation is another one that we've had significant success with. So you can either, core off the GE junction endoscopically, or now you can argon plasma beam it instead, and that's our preferred technique for this as well. And I've had some patients with some incredible successful outcomes that saved them complex revisional surgery perhaps. So I always think, as a minimally invasive surgeon, to do step-up approach and start least invasive and work our way up as well. So these are some things. Magnetic sphincter augmentation is not FDA approved in the US for it. It is for sleeve, but not bypass, but there are some people who are doing it post-gastric bypass as well. And then that resection plication is a version of the anti-reflux mucosectomy as well. Now we know that after OAGB, again, GERD incidence varies. The key is in this operation, not that it isn't in the gastric bypass where you can do a scintigraphy to rule out bile reflux as well. You just have to communicate well with your radiologist that it has nothing to do with the gallbladder. I'm wanting to follow this tracer, and does it go all the way up the rulum, through the pouch, and into the esophagus? But after OAGB, is that something that, could be more likely? We know that prevention, and those of you who have pioneered this technique, as illustrated here, to try and decrease the likelihood of that is important as well. And so when you are working these patients up, then it's obviously important to think about, am I going to just have to basically, in essence, convert this into a roux, or do I have to resect the pouch for reflux and do a roux as well? Because is it bile reflux, or is it acid and or bile reflux? In this study, they looked at that, and they objectively looked at the patients, and 30% of them had a pure acid reflux. 11% had mixed acid and bile, and then, believe it or not, another 3% had pure non-acid reflux as the cause. So this is important when the patient, I always say when the patient presents, when I'm talking to our residents and fellows, the patient's chief complaint is, they say, oh, the patient has GERD. I'm like, no, they don't. They have heartburn. Their chief complaint is heartburn. It's up to us to diagnose them and say, do they have GERD? Patients with achalasia can present with GERD, with heartburn, and they don't have that. And so it's up to us. They have stasis, right, causing the heartburn. They don't have acid reflux. They don't have an incompetent LAS. They have the strongest one around. So our job is to objectively diagnose the things based on the chief complaint the patient has. And I thought this was an elegant study that showed it could be acid reflux, it could be mixed, or it could be bile reflux. And that's going to possibly change the way that you choose to treat that patient afterwards as well. Again, are you just going to resect it, the OAGB, and basically convert it into a roux and put the bile downstream? Or do you think that pouch, for whatever reason, is too much along if it's mixed, and then you're going to have to resect that whole thing and do a reconstruction then as well, and downsize the size of that of that pouch, like we talked about, to make that smaller acid pocket. You know, we don't want as much parietal cell mass in there, because we know we're not doing anything to the LES. We're not augmenting it. All we're doing is, this is more of a permanent PPI in that situation, where you're trying to keep whatever aliquot is in there is still going through the incompetent LES. It's just, are the patients less symptomatic now or not? This was also an interesting study on the OAGB, where they did scintigraphy to look at that. And in these 9 patients, they had mean age was BMI 40, or at age was 56, BMI is 43. And when they went through the scintigraphy of these patients, it was interesting that what they said in these, at least in these 9 patients, was there was transient bile into the gastric tube after so much time, but that there was none in the esophagus. Okay, so transient bile gastritis, we talked about how you sometimes see that in the antrum after your sleeve. I think that's a whole nother area of research, Barham. I'd love to work with you. I've been trying to think, because I think the pylorus relaxes after sleeve, and I think we need to do some studies on that, because how else are you going to get the Barrett's after that? You have to get some acid plus bile mixing in the lower esophageal sphincter. But in this case, after OAGB, they saw some transient tracer in the pouch, but they didn't see it in the esophagus. So these patients may have symptomatic or asymptomatic bile gastritis, but they don't have bile reflux, right? That means it's come up through the competent lower esophageal sphincter, and in this case, the sphincters are intact, at least keeping that bile from going up. Now, I've been intrigued by some of the studies out there on this, especially, have any of you had a gastric bypass patient with abdominal pain, and you've done $1 million workup and you still can't find the source of their abdominal pain? Probably just me. Okay. This is one more thing I've added at the bottom of my algorithm, which is fascinating to think that there are studies where you can give ursodiol. Now, this isn't to prevent the gallstone formation. These are still in our patients that have already had their gallbladder out. But whether it's crystallization within the bile duct that has been described or not, but the key is they've actually used this on your patients. And it's interesting to see what percentage of patients can actually improve by just with this chronic abdominal pain. You've ruled out all of your other mechanical causes. You've looked 2 endoscopies. There's no hidden marginal ulcer. You've done all that. You did a laparoscopy. There's no occult internal heart. You've done all this stuff, and they still have this pain. And so it was interesting that in this study, 83% actually had improvement in their abdominal pain by using 500 milligrams of ursodiol BID. Now, it doesn't happen overnight. It has to take up to 6 months for this to improve. So the good news is, for that patient we're struggling with, you can say it's going to take 6 months, and it's at least 6 months before you have to see them back, right? Before you, but when they added ursodiol and the PPI, as you can see from the curves, the PPI added to the ursodiol really didn't make much of a difference. So it probably is more on the bile side of things as the culprit than the acid per se. And as we wrap up here, I want to talk a little bit more about SIBO, small intestinal bacterial overgrowth. These are the most common offenders. Again, for this is something to keep in your differential diagnosis for functional gut issues after our Roux-en-Y and OAGB. I can't get the breath testing done in my state because of the expense of it. You could have your friendly neighborhood endoscopist, either that's you or a colleague, could maybe go down and get some of that aspirate of the small intestine. And again, going back to our medical school understanding of physiology, the stomach has acid in it, which is good, kills bacteria, helps start protein digestion, does all these great things. Unless, of course, we're suppressing it. But that's why the foregut has very little bacteria in it. And so, again, elusive diagnosis, but if you're going to take an aspirate of that aliquot of that fluid in the proximal intestine there and looked at that, and there were more than 1,000 colony-forming units per cc, that could technically make the definition of SIBO. Now, it gets back to the difference between pathologic reflux versus objective symptoms, because you can be asymptomatic, and what do you do with that patient versus the patient who is symptomatic? These are a variety of antibiotics that can be used to treat it as well. In terms of drug and or dosing, this is one suggested algorithm as well for the use of treatment of SIBO as well. Now, looking at a prospective study, they looked at 40 patients in this particular trial. They looked at the weight loss, they did the jejunal aspirate, and it was positive in 77%, but the problem was, again, if you were just doing that for the purpose of the trial, the high incidence of these patients, it was, were asymptomatic. But it's out there. In this study, they said that overall it was 43% between OAGB and gastric bypass. The only flaw I saw in this study is they didn't fractionate out how many were the gastric bypass and how many were the OAGB patients. I wish I would like to have known that in that literature as well. But these are just some other things from a functional gut standpoint to keep in your mind. And in conclusion, I'd say yes to my dear friend, Dr. Helmuth Billy, who's a big proponent of OAGB. I'm, of course, a big proponent of the Roux-en-Y gastric bypass. But working together, is the bypass the answer? I would say, yeah, most of the time. Thank you very much.
Stand here. Shana, please have a seat.